Hi, everyone. My name is Sarah Kahn, and I'm a board certified clinical nutritionist specializing in digestive health. I'm the founder of Belly Bliss Nutrition, and with me is Erica and Kara from Solstice Physiotherapy. And why have I invited them here? Because they are experts in bloating, constipation, and digestive function, and I often refer my clients to them. And I would love to unpack how the pelvic floor and the mechanical things impact digestion and our symptoms. So, Erica, Kara, introduce yourselves.
Hi, I'm Erica Mikic, and I am one of the founders of Solstice Physiotherapy with Kara. And we refer a lot of our patients to Sarah because we treat so much, bowel dysfunction, IBS, that sort of thing. And patients ask us a lot of nutrition questions, and a lot of the times we can't answer them. So Sarah helps us out with that. And then we always say, me and Kara, like 90% of our patients have some sort of GI dysfunction. So it's so important that we all have like a connection here and work together. So this is awesome that we're doing the podcast.
And I'm Kara Mortifolio, or as Erica already said, I'm a co-owner with Erica. And Solstice Physiotherapy, we've been in business since 2019, and we see men, women, children, people, anybody that has a pelvic floor.
Great. All right, let's get into it. So most of our clients think of food as the triggers of their symptoms, but it's often mechanical. So can you help us understand what's going on underneath the hood, so to speak, and what we can do, what types of symptoms might have a mechanical cause or nature? Help us understand what's going on here.
Basically, like how we break it down with patients is that a lot of patients have either motility or an outlet dysfunction when it involves gastrointestinal disorders. And some and most patients have both. But when you have a motility disorder where things are either super fast or inflamed or super slow, and like, for example, constipation, essentially the outlet, if there is dysfunction in the muscle in your pelvic floor where the outlet of everything comes out, it could be difficult to go to the bathroom or have pain to go to the bathroom, or it could, result in bloating and things like that. So that we kind of describe it in two ways to the patient, right, Kara? You would say, right, like basically. And so that's like the easiest way to understand it. And because some of the patients come in and they're like, well, I go every day, but I'm straining, or I go every 5 days, but it comes out easily, right? So like, what is an outlet versus motility is kind of what we decipher.
And how do you determine the difference? Like an outlet versus motility.
Yeah. So, I mean, I think that some of the GI doctors can help with that. Obviously, there's different types of motility testing, like SITS marker testing. They could do, the smart pill test where they look to see, right, like how quickly things are going through. So that would probably help determine motility. And I would think the kinds of patients that might have motility issues would be people that have had prior abdominal surgery, maybe endometriosis, or a condition where there's like actually restrictions in their abdomen. And then in terms of like an outlet disorder, so that means the pelvic floor muscles are not working properly, you could diagnose that with an MR defecography, where they look to see, right, like they put you under MRI, they put some dye in and see, can you, push out a bowel movement. And you could also diagnose that with anorectal manometry expulsion test, which the GI doctors will do, but we can also use that tool in the clinic to help as an assessment and a treatment. So, I think most of the patients that come in have had, both of those tests, like tests for motility and tests for outlet dysfunction. So we do rely on the doctors to help guide us with that.
Yeah. And like, we will often see too that patients had normal motility their whole life and then go away, and we'll get some sort of like we always say like Dr. Ivanina, one of the GI doctors we work with a lot. She always says like sometimes patients will go away to like say they go to like some foreign country and then they get sick there. That can cause a lot of slow motility afterwards, or they have a really bad like stomach virus. Things like that can also trigger it. And we see that a lot because the patients maybe will get that and they're like, wait, all of a sudden, I never had this before. What's going on? And their pelvic floor kind of freaks out too because it's not doing its normal function of going to the bathroom. So we see that a lot as well. But also sometimes when the patients come in too, and they're coming in for like something like endometriosis or just IBS, and they haven't had any testing done, Tara and I and the other PTs will send them out a lot of times to get SITS marker, or we'll talk to the GIs to get testing done to make sure like they truly have slow transit, or there's truly nothing going on, and it's just pelvic floor tightness or something like that.
Yeah. No, you bring up a really good point about, going away or getting really sick. There is a real thing called post-infectious IBS, and we are learning that is a huge risk factor for SIBO. And they're not calling it an autoimmune disease or condition yet, but we do know that for a lot of people who have had traveler's diarrhea or food poisoning, that it can paralyze the motility of the small intestine or the large intestine.
Yeah, we see this so much, Sarah, so much more recently. It's crazy, right, Kara? Like, I don't know
Yes,
why,
absolutely.
but maybe we're just recognizing it a lot more, but it really is kind of prevalent. So it's interesting.
Yeah, we're also seeing a lot of post-COVID GI issues and GI disorders. People who've never had GI issues ever. They don't have food poisoning. They don't have a history of traveler's diarrhea. They have COVID, and then they have, SIBO or IBS. And I think we're learning that, the pieces of those virus particles get stuck, for a lack of a better description, get stuck in, the motility nerves, and they can hang out there for a long time. So,
right.
And like one of our biggest complaints, to answer your question, like about bloating, is like patients come in and like that's one of their biggest complaints is bloating. And that can show up in like so many different ways, as you know, Sarah. And I'm sure your patients too, right? Everyone, that's what they complain about.
number one. Yeah, that's
The number one. Yeah. And what's interesting for us is that we see like a variety of bloating, right? And you see this too. And some of it's just hormonal, right? So they're having that endometriosis belly and they're having inflammation and hormonal imbalances in that regard, right? Or something like PCOS that we see there. But then we also are seeing just bloating from just constipation and not emptying properly, right? So, and sometimes bloating is just from like core weakness too. So postpartum, that sort of thing. Right, Kara? I'm trying to think of what else would
Well,
be
yeah, no, I was going to
another
say
factor.
abdominophrenic dyssynergia,
Yeah.
which is a phrase that like more doctors are using. So all it just means is that the coordination of the diaphragm and the pelvic floor is not working properly. So things are contracting when they shouldn't be. And so patients that suffer from this, their stomach will be flat in the morning and then it'll be completely bloated by the end of the day. Or they go to like work out, and then after they work out, the bloating is way worse. So that's just a coordination between the two. So that's something that we can work on, but there also is some associated weakness with that as well.
Yeah. And like basically like your abdominal muscles aren't pulling in properly. So like the organs kind of sink down and it causes like a lot more bloating for the patients. And then we're also seeing some bloating on rare occasions, but we see it from egg freezing or IVF and fertility treatments. And that's, changing a hormonal balance in the body and changing their motility. And it could, induce inflammation or silent endo if you have silent endometriosis. So those are also things to think about if you all of a sudden see bloating in a patient that they never had before.
Yeah, absolutely. We've had a few clients who've come to us, again, never having GI issues before, go through the IVF experience. And, I think they are cautioned on, to expect some bloating as part of the change of the hormones. but they're not really counseled on the potential for long-term effects. And they're kind of shocked that 6 months later, they're still feeling a lot of bloating and having IBS issues. So we
Yep.
have seen that quite a bit.
Yeah, we have
does
too. It's
improve,
interesting.
it does take time.
Yeah.
But yeah, I mean, bloating is like the number one, the number one symptom that we see. And there's so many different causes. And, you know, what I'm looking for is, do they respond to dietary changes? Do they have SIBO? Do they have dysbiosis in the colon or overgrowth of other microbes in the colon? Do they have something that's treatable? And are we getting stuck? And if I feel like we're getting stuck, then this is a great sort of way to say, you know what, I think you should have a pelvic floor evaluation
Yeah.
because of the discoordination. And we've had a lot of clients with, and I always get the acronym mixed up. It's either ADP or APD.
Yeah, abdominal phrenic. Yeah, APD.
Abdominal.
APD.
Yeah. Yeah.
Yeah.
When my clients Google this, they're like, oh my God, this is me.
Yeah.
And the way I explain it, and you guys can correct me, but is like the diaphragm's supposed to move up when you eat to make room for the contents in your stomach and your intestines. But what's happening is it's pushing everything down and out. So, you know, my clients look, you know, they're the ladies who are posing in the mirror saying, why do I
Right.
look 6 months pregnant when I'm not 6 months pregnant? So, and then the other things we see is different forms of constipation. We have a lot of clients who don't realize they're constipated. They're like, well, I poop every day. And then when I show them the little cartoon poop chart, the Bristol stool.
Oh, Sarah, that's why we make them do bowel diaries, even if they tell us that they go normally, because we always are like, well, just let's see, you know, because what's normal to one person may not be in the normal range, you know, or so we make them like record it. Yeah.
Absolutely. So, you know, they either might be straining or they might have, for those of you who don't know what the poop chart looks like, it's like cartoon poop. But there's, you know, small pellets or smaller, you know, hard and formed poops versus like long, smooth poops. But people who have what we call incomplete evacuation, where they're going to the bathroom, but it's like a bunch of smaller poops throughout the day or every other day. And they think, you know, I'm not constipated because I'm going. So explain a bit more about like incomplete evacuation and what might be going on there.
Yeah, so like we can just give you like a whole picture of like, so when someone comes in and they're bloated and they're constipated, we first want them to do bowel diaries for us to just see really like what's going on. They have to do it for like a week or two, but we keep doing it until it's normal, right? So we tell them, okay, on the diary, tell us if you strained, and we explain what straining is, tell us if and what your stool consistency is, right? So that they can actually look and see, oh, I'm actually like a 1 or a 5 and not a 4, you know, or a 3. So we do that first, but then we check their abdominal wall, and we teach them how to do an abdominal massage to their colon. We do abdominal massage to the colon. We work on any like adhesion, scar tissue, that sort of thing. And then we can also do biofeedback on their abdomen and their pelvic floor, to treat some of the abdominal phrenic dyssynergia to make sure that they're breathing and their diaphragm and their core is contracting properly. And then we are checking them internally if they're okay with it, internally, and we're seeing, okay, can you bear down? Can you actually bear down appropriately with force without holding your breath and valsalvating? You know, like that would be like like when patients tell us they pass out on the toilet, like, or they like pop blood vessels, like that means you're valsalving. That's not the right way. But what happens is the patients will get incomplete evacuation because their pelvic floor actually contracts when it should relax to let stool out. And then we're teaching them how to properly like relax the muscle and breathe out as they're going to the bathroom, to avoid incomplete evacuation. But with poor like bowel mechanics of like pushing, and over time you could also get something called a rectocele, and that will also pocket some of the stool too and also give you incomplete evacuation. Also, the pelvic floor contracts so much that you actually will like almost stop letting stuff come out, and then you'll feel like there's something stuck in there too. So, right, Kat, anything to add?
No,
That's
I
like
mean,
a
the other
basic
thing,
overview. Yeah.
yeah, that's the base. I mean, I think the basic thing too is that if the longer stool sits inside your colon, the more water gets drawn out. So then those are those people that have those little like pellets, right? Because they didn't let it all out the first time. So it's just been sitting in there and more water gets drawn out of the stool.
Yeah, so then we really, really work on stool consistency. And it's very, for basic for us, increasing water, eating more cooked food, cooked veggies, less raw, having the appropriate amounts of fiber, and maybe if they need magnesium. We do a lot of like weaning off of enemas and weaning off of Miralax or Senna, people that have like used these medications for years, so we do that. But we only do that a portion because a lot of these patients also need nutrition counseling too. Even just skipping breakfast makes a huge difference. So like you know this, Sarah, like we're preaching to the choir here, but like, like things like, oh, I don't eat breakfast. We're like, oh God, well, this is gonna have to change, and so
Yeah.
we do, all slow. And we always tell patients the bowel is the slowest learner. It takes so much time. Bladder is much easier to fix quickly. The bowel takes, every time you make a change, you have to wait like really 2 weeks to see it change with food, with supplements, probiotics, things like that. So,
Mhm.
digestive enzymes. And so there's just so many, it's so complicated, but it's also like, it's so much, it's fun to treat because you really see true change in people, right? But yeah, so, and a lot of times we really see a lot of incomplete evacuation complaints, and this is kind of how we start to treat it. Everyone's a little different, so you have to kind of go by what
Yeah.
their habits are. But yeah, but,
What
the men
are
wake up and go to the bathroom immediately, some of the men, it's so funny, like
what are some of the causes of constipation and incomplete evacuation? Like, what are you seeing are the drivers of this?
I mean, I would say, well, we do see a lot of people with endometriosis,
Mhm.
which there's that hormonal issue and that pain issue, right? Because they've had pelvic pain, and so those pelvic floor muscles are clenched. Other causes of constipation, I mean, just general hypertonic pelvic floor muscles, so tight pelvic floor muscles that could come from a hip issue, it could come from a bladder issue, it could come from, a surgical issue. Um,
what about like people pushing off urge at work? They don't want to go to the bathroom,
yes.
Mm.
like at work,
Hmm.
or they're embarrassed that they can't go in like a stall, things like that. So they push off urges, and then your urges get less and less over time. And then, you have stool sitting in there, and then your pelvic floor gets tight, and then you start straining, and it's like this vicious cycle. So we see that. Oh, crash dieting, right? Um,
Hmm.
what else?
Yeah,
Oh,
I would say
even
trauma too.
yeah,
Trauma.
yeah, yeah, yeah.
Yeah, if people have had like sexual abuse or physical
Mhm.
abuse, they may tend to not withhold stool, but kind of hold more tension in their pelvic floor muscles and then just make it harder for them to go.
Yeah,
Yeah.
and then we have patients that's like, my, parent made me, go to the bathroom before we left, and, habits like that. So things like from childhood, really. I mean, we have patients that have been on a lot of, meds and stuff since they were kids, and, just from like constipation as a kid, and then it just kind of like is like this vicious cycle.
Mhm.
But we also, have seen so much IBS, patients with IBS that actually has associated endometriosis too. So it really goes hand in hand a lot of the times.
There's so
Not
much
everyone, but yeah, there's a lot of overlap. Yeah.
for sure.
Oh, and then we also see too patients with Ehlers-Danlos syndrome. So it's like hyper tonicity like throughout the body and in the joints, and they have a lot of like rectal prolapse and slow transit. So they have slow transit, and it's hard to get stool out because everything is so lax in their body. So we treat a lot of this as well. Yeah. So
I mean, I'm glad you touched on quite a few of these because
yeah,
there really are so many different root causes. And it's so important to really do a deep dive into the health history and habits and lifestyle, even something as simple as, like you said, that not that it's simple, but it's very common to see people who are jumping on the trends, the dietary trends, and carnivore and intermittent fasting and all these different diets, and their bodies are responding in a not so great way. So we see a lot of that. And with food restriction, I like to describe the digestive tract as like an assembly line. Like you got to keep things like going in order to come out. So that's why eating breakfast and eating full meals and not picking all day long can be really helpful for digestion as well.
And even like with the trend of Motegrity now, which is also, and this, Sarah, too, like affecting their, giving people constipation, giving people nausea. I mean, now we're seeing that as well. So patients that have already been coming in with pelvic floor dysfunction, pelvic pain, and a slew of diagnoses that are now trying Motegrity, it's also now making some of these things worse. So
you mean Ozempic, right? Ozempic?
I'm sorry, what am I saying? Motegrity. I'm so sorry. Ozempic.
You mean Ozempic?
Oh my God. Yeah. Erase the Motegrity. Motegrity, we love. We love Motegrity. Ozempic. Yeah. So it's slowing like one of the, like a doctor told me once that the Ozempic stays in your system for like weeks, like food could stay in your system in your stomach for weeks, which is so crazy. So it's really, it affects, like if you have a pelvic floor dysfunction, maybe Ozempic, you wait till that resolves before you try Ozempic sort of thing. But people don't know that,
Yeah.
So
my colleagues and I are preparing ourselves because I feel like we're going to see an onslaught of people who have tried these type of medications for weight loss and have, resulting GI dysfunction. But it's fairly new concept for people who don't have diabetes taking it. And we're not being taught think about it from a nutrition standpoint, how to deal with, the aftermath. But going back to Motegrity.
Motegrity is great. Yeah. That's helped a lot of our patients.
Yes. Motegrity is a motility drug that can be helpful, but like with all medications, it might not be well tolerated. And we do see folks who don't do well. And they can lower the dose, and hopefully they can land on the right dose, but it's not right for everybody. And for other people, it makes a huge difference. So we do see a lot of that. I know we have to wrap up. I know we can talk forever on these topics. We had so many more topics lined up, which we will get to next time. But what are maybe your top 3 practical things someone can do at home or can start to think about to alleviate? Let's start with just bloating. How can I make my bloating better? What can I do? Have any thoughts there?
I can start.
Yeah, start, Kat.
So I'll give 2 things. So I think that in terms of helping your bloating by helping you eliminate more completely, I would just make sure to listen to your urge to have a bowel movement and do not push it off. So if you get an urge, you need to go, I would say within 10 minutes. And then the second thing would be, I would definitely try a squatty potty or a step stool to elevate your knees above your hips because it opens up your pelvic floor. Those are 2 pretty easy things to do, which will hopefully allow you to evacuate more completely.
Yeah. And with the urge too, don't go if you don't have an urge too, but that's just to piggyback off Kara. And then another thing would be you could just practice basic do an inhale and let your belly get big. And when you exhale, pull your belly in towards your spine. And that will arrange your diaphragm and your stomach to be coordinated better so that it's not going to push organs down. It like keeps the anatomy proper. So you inhale, let your belly get big, exhale, pull your belly in, and you could practice that when you're working out as well. So
And
just
are
to
you
carry over in
breathing in and
everyday
out
life.
of the nose or the mouth, or it doesn't
Oh,
matter?
out of your nose.
Nose. Yeah, I think nose.
Yeah,
Yeah.
nose. Yeah.
So it's
Yeah.
diaphragmatic breathing.
Yeah, but like when you exhale, yeah, you want to like contract your core. So almost like a core
More
engagement.
forceful.
Yeah, more forceful. Yeah. So you could do that like just as practice as an exercise and kind of like put it when you're doing Pilates or yoga or something. It could help like decrease some of the bloating. So you get like all angles, like doing bowel stuff and doing core strengthening. So you touch all the areas.
I love it. Those are easy. Those are
Yeah.
simple. Those are things that everybody can do.
Mhm.
Thank you so much. I really appreciate your time, and hopefully this video will be so helpful to our clients and our audience, and I hope to talk to you guys soon.
Yes. Thanks, Sarah. Thanks for having us.
Thank you.
All right.